development happened in the last few weeks when it comes to the conversation around decriminalization, that we actually look into this. And we haven't heard from the federal government where they're at. What we have heard is the Minister of Mental Health and Addiction say that she is not planning to take any immediate action. We have heard that the police in British Columbia do not have the tools they need to keep people safe. We have heard that addictions have gone up. We have heard that overdose deaths have gone up. We have heard that there is crime and chaos and disorder running rampant in our communities. And so I think it is absolutely incumbent on us, especially as we've been undertaking this study, to continue looking into this, because this has developed quite quickly since we had Fiona Wilson, the Deputy Police Commissioner from the Vancouver Police Department, come in and state that they had no tools to be able to do their job. And so I would ask that we be able to have this study go forward, expand this so that we can have those ministers come in and explain from their perspective how we should go forward in this so that we can make sure that all Canadians are safe and that British Columbians are safe. There are 6 people every single day that die in the province of British Columbia due to overdoses, and it's incumbent on us that we're taking every single one of those lives seriously, that we are doing everything we possibly can as legislators to make sure that both public safety and public health are being taken into account. So I would ask that people support this motion.
Okay. Thank you, Ms. Goodrich. A very similar motion was put on notice, but because it directly and clearly relates to the matter we're studying, the motion is in order. The debate is on the motion. Dr. Pelosi and then Dr. Ellis.
I note that we had pretty extensive discussions a couple weeks ago about the disorder caused by public use of drugs. I'm actually very happy to see the announcement of the Premier of BC to again criminalize the public use of drugs. I personally don't disagree with this, but there are a whole raft of other issues related to the opioid crisis, and indeed we're talking with some of the experts on a lot of those other issues. I think there is going to be a need, and I probably would agree to extending the study, but it'll perhaps be on other issues as well. Given the importance of the witnesses we have here and the fact that we'd like to ask them other questions and address other issues related to the opioid crisis, I'm moving a motion to adjourn debate.
Thank you, Dr. Pelosi. As we know, a motion to adjourn debate is not debatable and must go directly to a vote. So the question is, shall the debate on this motion now be adjourned? All those in favor of adjourning debate, please raise your hand. 1, 2, 3, 4, 5, 6. All those opposed? A recorded division, Madam Clerk, please.
Apologies for the delay. Okay, recorded division on the question of adjourning debate. Dr. Hanley.
I support.
Madame Lapointe.
Oui.
Madame Brière.
Oui.
Dr. Pulaski.
In favor?
Ms. Sidhu.
In favor?
Mr. Doherty. Mr. Ellis.
No.
Dr. Ellis, my apologies. Ms. Goodridge.
No.
Dr. Kitchen.
I can't hear.
Dr. Kitchen, to adjourn debate, in favor or against?
Point of order, when they turn my mic on without me turning it on, I can't hear. It shuts. I'm deaf in one ear, and this plugs this off. So you called my name?
Yes, sir.
No.
Thank you, sir. Mr. Thériault?
Oui.
Mr. Johns?
Yes.
1, 2, 3, 4, 5, 6, 7. 7 yeas, 4 nays.
The motion is therefore adopted. The debate is adjourned. We're moving on with questions. Next up, Madame Brière for 5 minutes. Yes, Mr. Doherty.
I believe Ms. Goodrich had 30 seconds prior to moving the motion just to extend this debate, or just to extend this study.
From the stopwatch that I'm looking at, she was, by the time she moved the motion, it was very close to time. So it's certainly not enough time to allow for a question and answer. So I recognize Ms. Briere, please.
Merci, Monsieur le Président.
Thank you, Chair, and good afternoon to all our witnesses. Thank you for joining us in this important discussion. Dr. Cottarella, could you tell us how abstinence, forced abstinence and disintoxication increases the risk of death of someone who is actually trying to tackle their addiction?
Merci pour la question.
Thank you for the question. So this has been a tool for a long time. We use it for many substances.
Mais quand ça vient au...
When it comes to opioids, a period of abstinence reduces tolerance to opioids. So when people are in that period of disintoxication, they have an elevated risk, actually, of dying. And the same, these are the kinds of cases we can see in prisons, for example, where there is forced abstinence or mandatory abstinence. We found that people who leave prisons, who are released, are 10 times more at risk, actually, of dying. So there has to be agonist therapy, agonist treatment for opioids, whether it has to do with it being in detox centers or in prisons. Thank you very much. Dr. Morin, you spoke about comorbidities. Substance use can make mental health issues worse. Some people also use to forget their mental health illnesses, to escape them. So what comes first? Is there a problem of mental health first? Or is there a substance use problem first? And what do you think needs to be treated first? Should they be viewed as two independent problems but that impact each other? How do you view that? Well, that is a very important question, you know, the chicken or the egg. Everyone wonders about that, but I'm going to put it in perspective. There are two kinds of mental health issues connected with drugs. There are comorbid diseases. So, for example, someone may self-medicate. Let's say someone uses alcohol to treat their anxiety. Many anxious people use alcohol to self-medicate, but we know that anxiety came first. Now, there are some mental health issues that come about because of alcohol use or because of a drug use. Let's take cannabis, for example. There may be students who suffer from ADHD, but these might have been induced by consuming. So it's very important to diagnose the primary pathology and to treat that main pathology first. So what we can't continue to do is say, stop using, and in 6 months I'll start treating the other issue. They have to be treated at the same time. So the addiction and the mental health issue. And this is actually treating comorbidities. But what came first? That's still a question, outstanding question. Do you know, sometimes you can see these things clearly when people have been using less or not at all, when that period of abstinence has had enough time.
Dans la poursuite de la question de...
Thank you very much. I'd just like to follow up on one of Mr. Theriault's questions. He asked you how you would speak to young people when it comes to prevention. Earlier in one of the answers, we heard that when people are looking for stronger drugs, they're not necessarily looking for safety. They're looking for something stronger. So what would you say to them? Well, they're looking for that buzz, aren't they? People use for two reasons, either to relieve them of pain or to increase their pleasure. So what I do is go through peers. I bring someone with me who has recovered, for example, someone in their early 20s. So a young adult who perhaps might have been part of prostitution or street gangs or drug use. So I'm not the star when it comes to bringing this person. They are, and it has an impact because you're talking to a young 20-year-old who has had to go through all these experiences, and it has a much greater impact than the doctor who's giving them a speech. It works very well. They're really impacted by it. They're marked by it. They remember this person who was able to get out of that at such a young age. Thank you, Ms. Morin.
Dr. Ellis, please, for 5 minutes.
Thank you very much, Chair. Thanks for everyone for your answers thus far. I really want to focus a bit on prevention, if I could. I'll start with you, Dr. Matthew. You'd spoken a bit about prevention. I realize you're a forensic psychiatrist, and again, if it's outside your scope, just feel free to do so. But it would appear that substance use disorder is a problem that could start very early, but perhaps is something that we need to spend some money on with respect to prevention. We can talk about things like resiliency. We can talk about exercise. We can talk about friendship. We can talk about meaningful lives, all of those things. Are there programs out there right now funded by the federal government that are talking about prevention? Or do you know that answer? And if you don't, that's fine. And if you could just talk a bit about prevention, how you see it as well.
Sure. So I work in addictions and I also work in forensics. I do both. As far as there are education campaigns to help people understand the toxicity of the drugs out there, but there are other programs that are available. So, for instance, in Iceland, they had a program where they gave vouchers to families to put their kids in extracurricular activities, and they also had I forget the age of the kids, but under a certain age for teenagers, there was actually a curfew. And so people were encouraged to not go out at night and also engage in sports. And this dramatically reduced the alcohol and drug use in that country. The other thing that I would mention is lowering the amount of opioids in the street supply. I think that's an important way of primary prevention. And also things like access to therapy and early treatment so that the substance use disorder or the mental health disorder that can cause a substance use disorder doesn't progress to something where a substance use disorder becomes severe.
Dr. Morin, la même question, s'il vous plaît.
Same question to you, Ms. Morin. Dr. Morin? You are on mute, Dr. Morin.
Because I think it's similar to what I said to Madame Brière.
It is very similar. I guess I was just wondering, do you know how federal government money funding prevention at the current time? Are you receiving any federal government funding for the prevention that you're doing? And, could you talk a bit about what a good prevention program might look like?
Well, I can try in English. Well, actually, I myself opened my own clinic in 2015 in Montreal, dedicated only to addiction. And I had to close the clinic in 2020 because provincial government told me it was not a priority. Priority was COVID at this moment, so I had to close my clinic. The name of the clinic was Clinic Chameleon, like the animal, a chameleon. I think if you want to work in addiction, you need to be a chameleon. You need to change the context depending on the question. If someone wants to reduce drug use, it's already good. If someone wants to stop, it's very good too. But you have to adapt your approach to what the patient wants. And one final thing I would say is my mentor used to tell me that working in addiction is like working in intensive unit care. If you don't treat them when they're ready, they die. And that's what we see. So we always have to be ready to help when they're ready.
Merci beaucoup, Dr. Morin.
Thank you very much, Dr. Morin.
Same question for you. Are you aware of federal government spending on prevention programs, and what might an ideal prevention program look like to you?
Thank you. So the evidence-based prevention that we have, we know what doesn't work, we know what works. We really have to look at community-based, school-based, and family-based programs. And they're really ones that both build skills, they build resilience, as you mentioned, but also ones that help people understand and create more linkages. Many of the communities that we're talking about around the country have a lot of strength within them, and it needs to kind of be tapped into. Often it's about supporting communities to figure out what are the needs in their communities and how to answer them. I think, unfortunately, every jurisdiction in this country is guilty of responding to a crisis with a kind of shorter lens. We responded by trying to treat everything that was downstream. And as I said, with the first crisis declared 8 years ago, those kids were 12 at that time. They're now the ones who are dying. I hope that every government in this country, and municipal, provincial, and federal, is able to reinvest in prevention and seeing it has a role as part of that continuum, but that it also has a role in terms of the long-term hope of solving these bigger issues. Thank you.
Thank you, Dr. Cardarella. Next, Dr. Pawlowski, please, for 5 minutes.
Thank you. So a couple of weeks ago, we talked about the public disorder, which characterizes a lot of downtown areas, seemingly swirling around drug use. But and I'm glad to see a couple of people here who are talking about mental health issues in part of this discussion. So I'd like to talk more about how much of the problem is drug use and how much of the problem is mental health disorders. Now, we've also talked about it being difficult to distinguish between the two as being a chicken and the egg problem. Some drugs like methamphetamines, even marijuana, can cause psychosis. But maybe I can start with Dr. Matthews, but maybe go on afterwards to Dr. Moran. How much of the kind of downtown east side scenario, which is homelessness, drug use, crime, social disorder, how much of that is really a drug problem, and how much is psychiatric problems that are being inadequately addressed? And with respect to that, I've certainly, in my last number of weeks in considering this issue, I've talked to psychiatrists about the availability of treatment and treatment for addictions, and they kind of said, well, Marcus, there's no beds. Like we discharge people from our psychiatric unit with rope burns around their necks from trying to hang themselves. So how are we going to find beds for them? So there's not enough beds. There's certainly not enough outpatient services. I've also heard from someone in Thunder Bay. They said there should be like 100 people in Thunder Bay on court-ordered treatment, long-term antipsychotics who aren't. And part of the problem is apparently concurrent disorders and distinguishing between psychiatric problems and addiction problems. And then how much are these problems a result of not enough chronic care beds? We closed all the chronic psychiatric hospitals years ago, and that was replaced with long-term antipsychotics. Should we be re-examining whether that's an issue? So I know I've talked about a lot of this, but maybe Dr. Matthews, you could start off in addressing some of those issues relating to the intersection between psychiatric illness and addictions.
Sure. There's a lot to unpack there. I'll start with the last point that you were mentioning. So when you look at schizophrenia, one of the most robust statistics that we have in schizophrenia is about 1% of the population will have schizophrenia. So in British Columbia, million people with in the province, there'll be about 50,000 people with schizophrenia. Then when you take those folks with schizophrenia, about 20% will be able to take medication, never have a relapse, live pretty normal lives. 50% will have a relapsing remitting illness, and 30% won't respond to medications. And so what do you do with those folks that don't respond to medication? And there's a high amount of substance use also within this population. So if you have an illness, an intrinsic organic illness that causes you to have psychosis, a lot of times substances like crystal meth or cannabis use disorder. So with crystal meth, in my treatment facility, that's the most common substance used, and it's about 2/3, and about half also use cannabis. So when they use these substances, it actually destabilizes them as well. So you were speaking about the closing of mental health facilities. So Riverview closed down. That was the big asylum in British Columbia. And one of my friends and colleague, Dr. Christian Schutz, did a study, and what he saw was that 10% of the folks in the downtown east side were old Riverview patients. So this was back, I think, in 2005. So it's an older study, but it shows what happens when these folks aren't housed. And so we're talking about thousands and thousands of these people. So you do have to provide long-term supportive housing for these individuals. And I think that's one of the key things that's missing in the spectrum. So right now, at this moment, I'm in Switzerland. And the reason why I'm in Switzerland is I'm trying to figure out how is it that they're treating substance use and mental illness so differently, and how do they have so much better retention rates? And one of the things is they have just wraparound services, and they have supportive housing. So every patient will get a social worker, they'll get a nurse, they'll get a family physician, they'll get a psychiatrist, and these folks will follow them longitudinally in the community. And also with the housing, they'll have support getting medications provided to them. So there's so much more support out there in the community, which we don't seem to have in Canada in comparison to Switzerland. Regarding your first question about violence and mental health issues, I actually don't have any statistics on this. I can tell you anecdotally what I've been seeing. So one of the things that I do is overnight assessments for the courts. And what happens is someone commits a crime, they get arrested, and then there's concerns about their mental health and whether they should be at their bail hearing the next day. And so they ask me to assess the patient to see whether they are mentally well enough to go to court the next day. And before the pandemic, roughly 1 in 5 folks that I saw for overnight assessments were random stranger attacks. So they didn't know the victim, and for whatever reason, whether it's an intrinsic organic psychosis or a substance-induced psychosis, they went and attacked someone. A couple of years ago, that became 1 in 2. There was a dramatic increase in stranger attacks. Now I think it's decreased to maybe 1 in 3, but there has been an increase, and I think there's a lot of issues with this. I think one was the destabilization that occurred with COVID.
Thank you, Dr.
Two, and I meant, so go ahead.
Yeah, thank you. Very interesting. I was reluctant to interrupt, but we were well over time. Monsieur Thériault, 2 minutes et demie, s'il vous plaît.
Dr. Morin.
Dr. Morin, earlier you were saying that you have to be there in intensive care when the patient is there and ready. There's a problem with the illicit drug crisis, and that is that patients don't necessarily come to the hospital in an ambulance to intensive care. So we have to be where they are. And if there's going to be some kind of process, whether it be therapy or any other, there has to be a link that's established, a connection with them. Could you tell us about how that can happen? And you're on mute. Well, I'll give you a very concrete example. Projet Caméléon, the organization that I set up at the beginning of the crisis, involved doctors, pharmacists, nurses, medical students, volunteers, street workers, and we went into, for example, electronic music festivals, where most people, if not all, are under the effect of a drug. So we would see overdoses there. There aren't a lot of opioids in electronic music festivals, but there are a lot of magic mushrooms, for example, and LSD. Now, when we were at the Eclipse Festival in Gatineau, in Sainte-Thérèse-de-la-Gatineau, there were 27 ambulances. There were paramedics, but there weren't doctors. The first year that our project started, by being there were only 4 ambulances. And last year, it was a record. There were 0 ambulances. So we treated people right there in place. We had antipsychotics. We had naloxone. We had benzodiazepines for panic attacks. So we saw that when you go to where the people are, you can avoid deaths. I'm certain that we did that. And we also avoided hospitalizations that weren't necessarily. Now, there are services in the street There are many of these services, and we also have substance analysis services. So that's what we do as well. People get their substances checked before they use, and if there are any traces of fentanyl, people don't use them. People were saying, someone said people are looking for fentanyl in the street, and it's true. It's true. There are people who are looking for fentanyl, and they're addicted to fentanyl. They need that fentanyl, and they're looking for it. But now there are even worse products out there. There are many other opioids that are even stronger than fentanyl out there. So in terms of services being offered in the street, there has to be an analysis of these substances because that can save lives. And contrary to what people may think, it doesn't increase people's use. Thank you very much.
Please, for 2.5 minutes.
So again, back to Ms. Wilson, the president of the BC Association of Chiefs of Police. She quoted she said this at our last meeting, quote, "We know that diverted safe supply, diverted prescription medications are not what's killing people. And also when you consider the volume or the potential volume to scale up diverted prescriptions, diverted safe supply, it pales in comparison to what organized crime are doing in terms of fentanyl production, importation, and exportation." We know, maybe Ms. Schultz, you can talk about how easy it is to get toxic fentanyl on the streets of Canada and how hard it is and what the steps are to get a safer supply in the provinces that allow it. And I'm giving you time, and I apologize to the other witnesses, but I'm giving you the rest of my time, 1.5 minutes, because I know some politicians don't want you and other mums to be heard. I'm going to make sure you get that time to speak.
Thank you, Mr. John. We all know how easy it is to get any illicit drug anywhere in the country, and that drug dealers don't check ID. I had the example of young Olivia who died. In terms of safe supply, there are huge barriers for people who need this to save their lives. In British Columbia, where it is available, it takes a prescriber who is willing to work with the person, and only a small number of people, roughly about 5% of the people in British Columbia who could benefit on it, are on safe supply. In Alberta, thanks to a court injunction, we have one person left on safe supply who thankfully is doing well. She would be dead today. She said that to me. She would be dead today if it wasn't for the court injunction. So we throw huge barriers into people's way for a life-saving measure. Whereas it is easy to buy on the street and it is too often lethal. But we also ignore that people who die are not only those who need treatment, they're people who use occasionally. There are people who just use once, like young Olivia. These are the people we need to see as well, and that is where issues like drug checking are important. So we need to remove the barriers to save lives and implement evidence-based measures. Otherwise, the numbers in this country will continue to climb. And at the same time, start making treatment immediately available when somebody wanted. Work on prevention. But as nobody has talked about on prevention is poverty, the influence on poverty. You don't have prevention with just some education programs. You have to make sure that people have good lives.
Thank you, Ms. Schultz. Next, Ms. Goodrich, please, for 5 minutes.
Thank you, Mr. Chair. Dr. Matthew, BC developed protocols to prescribe recreational fentanyl to youth. I'm just wondering if you could share with the committee what your thoughts are on providing recreational fentanyl to youth rather than mental health and addiction treatment.
So one thing I think is important is I don't think we should rule out any intervention outright, but we need to apply the precautionary principle in the development of such protocols. And so what does that mean? There was an author, Nassim Taleb, he produced a paper in 2010, and what he said was that you have to look at two factors. One, is the risk systemic or is it local? And is it cause a low amount of damage or a high amount of damage? And for something like this where you're increasing the supply of fentanyl in the community, that would fall under systemic risk and high downsides. So that would be the type of thing that you would apply the precautionary principle to. So what you would want to do is you'd want to figure out if this worked first. So if that was something that needed to be done, we need to look at small pilot projects that are rigorously and objectively look at the upsides and the downsides. And many of the studies done so far in these areas do not look at downsides. So that way we can measure the risks and benefits of such a program. And if such a pilot program took place and showed objective benefits that outweigh the risk, then that is something that should be implemented. However, if this has not been done, we should look at the precautionary principle when we have interventions that can increase the supply of addictive drugs in the community.
Do you think it's problematic to have basing political policy decisions on pieces that have not been rigorously studied and where we're only looking at the impacts to people that are using drugs and not to community and public safety?
I think we definitely need to have a 360-degree view in these things. We need to look at the upsides and the downsides, not just to the treatment population, but when you're looking at the supply of addicted drugs, you have to look at it at the population writ large. In the 90s, when physicians were pushed to prescribe opioids, it was to treat pain as the fifth vital sign. And that was Dr. James Campbell, who was the president of the American Pain Society. So this was a very respectable individual that was pushing this. But this led to huge amounts of downsides. So we really need to study the upsides and the downsides. Because as a physician, you want to know that what you're prescribing, the risks outweigh the benefits.
The Oxycontin crisis. So are you seeing similar things when we're looking at what the safe supply, which is flooding our streets with potent opioids? Are you seeing something similar to what existed in the 90s with the Oxycontin crisis?
So I want to take my opinion out of this, and I just want to look at what the government has produced. So there was a document called Youth Unregulated Drug Toxicity Deaths in British Columbia. And what they looked at was the years 2017 to 2022. And what they found was that if you looked at the deceased youth, there were 0% deceased youth with hydromorphone in their system in 2017, 2018, and 2019. In 2020, the year Safe Supply came out, 5.5% of the deceased youth had hydromorphone in their system. In 2021, 8.3% of youth had hydromorphone in their system. And by 2022, this number had increased to 22.2%. So what we're seeing is an increase in number of youth that have hydromorphone in their system at the time of death. So I want to be clear. This doesn't mean that the youth died from hydromorphone, but it certainly doesn't help to have hydromorphone in your system at the time of death. And what I worry about is that this might be a marker for increased use among youth. We don't know. That needs to be studied more, but it's certainly something that needs to be looked into. And the data for adults hasn't been released. So I just want to stick with the facts, and those are the statistics for that.
Well, and I really appreciate the fact that you want decisions based on facts and not on pieces here. And I think this is one of the challenges, and I know members of the NDP like to say that we're spreading disinformation. And the reality is I simply want public policy decisions based on facts and peer-reviewed science and not based on feelings and trying to save the world while allowing the next generation to succumb to addiction because we've made drugs so much easier to access. If you could say something to youth right now that are potentially thinking about using and going out and buying safe supply hydromorphone, what would you tell those youth in British Columbia?
As briefly as you can, Doctor, please.
That any sort of opioids are addictive. And with something like hydromorphone, if you become tolerant to it, you might actually move on to more dangerous things like fentanyl. So be careful around any sort of opioid use.
Thank you. The last round of questions for this panel will come from the Liberal side. I believe Dr. Hanley.
Thank you, and I will leave time for Dr. Pawlowski as well, especially if you remind me. First of all, I just wanted to thank my colleague Dr. Ellis for bringing up Planet Youth and prevention, and I just want to emphasize again, as Michelle said, how vital that is, and just to note, because not everyone may know this, but there was $20 million in funding dedicated in starting in 2023-24 in the federal budget for Planet Youth initiatives, with up to $125,000 funding per community initiative. So this is a great start, I think, in another avenue for prevention, which we need to be very aggressive at in supporting our youth. Dr. Matthew, just very briefly, I really commend you for being in Switzerland. I wondered if you have also been in Portugal.
I have not been in Portugal.
I just wanted to clarify, because there may have been a misperception that coercion is part of the cornerstone of Portugal's approach. And I was fortunate to be able to travel with my colleague, Mr. Johns, to Portugal and to directly have a prolonged meeting with Dr. Gurlau. Coercion is definitely not part of the Portugal approach. There is a dissuasion panel. There is a host of measures using the five pillars, including reintegration, that really address the client's needs, whether it's housing, whether it's harm reduction, whether it's Suboxone or methadone, whether it's readiness for treatment, along with the capacity for all of those, based on compassion. We have time. Based on compassion, central coordination, and an integrated approach. And I just I'll pass to Marcus, and maybe I can get 1 minute back at the end, Marcus.
I'd just like to let Dr. Matthews finish his story about increasing random attacks. I think he was going to tie that into mental illness and drug use, but maybe you could just finish that story, and then I'll give it back to Brendan if we have any time.
Sure. So I mentioned it in my talk, but I think one of the big issues is the rise of phenyl-2-propanone meth. And I said that earlier in my introduction. So when they were making crystal meth, there's two enantiomers, so two types. They're like handedness. So the L-methamphetamine is a nasal decongestant, and the D-methamphetamine is the psychoactive component. And they made it so that it's pure D-methamphetamine. So when you take the same amount, you're more likely to have a psychoactive outcome. And so I think the rise of this in the drug market has helped fuel a lot of the psychosis that we're seeing. So I think all of these things combined are the things that are leading to increased random stranger attacks in the population.
Thanks. Okay, excellent. Mr. Cordarella, Dr. Cordarella, sorry, I wanted to come back to you and to talk. I mean, we have touched a little bit on decriminalization here and there during this meeting. I know that you are based in BC. I wanted to know what should Canada learn from the BC pilot to date, and what would you be advising Toronto and potentially other jurisdictions about what to incorporate to make a decriminalized approach successful?
Thank you. Although I did work in Vancouver, I am now based in Ottawa, actually. So I think that there's a number of really important lessons. And first of all, I mean, most decriminalization or alternatives criminal to criminalization have required various adjustments at various points. I think the community has made it clear that they want to be involved, that they want to negotiate part of how public spaces are used, and we need to create more opportunities for people to talk in different ways. And I think there needs to be really good access to treatment, but also I think we need to remember that if, for example, we're going to ask a police officer to take someone to hospital instead of to jail, and I can tell you because I've seen this so many times, we can't expect the police officer to wait there the whole day for the patient to be seen. So I think there needs to be a lot of different levers. I think we need to make sure that there are tools in that toolkit. But what we've heard from law enforcement, what we've heard from partners we work with, is that this is part of a long arc that's trying to kind of not punish the people for the symptoms that we're trying to treat. At the end of the day, the goal is really to provide people with as much access through as big of an open door. And what we're hearing from people is that they want to be part of this. So they want to have discussions. And CCSA will be hosting a summit in the coming months around open drug use, actually, because people want to be involved in this discussion. They don't want to penalize people. They don't want to punish people, but they want to have this discussion about what it is. And we need to listen to people. We need to adjust, and not just small groups of people. We need to make sure everyone's involved in that discussion.
Thank you, Dr. Cardarello. And that concludes the questions for today's panel. I want to thank you very much for the passion that you bring to your work and for the patience that you've brought to this meeting. All of it is greatly appreciated and will be extremely valuable to us in making recommendations to Parliament and to the government. Is it the will of the committee to adjourn the meeting? We're adjourned. Thank you.